Hi there! Welcome again to another lecture in Counseling 5480 course. This is Dr. Luo, and we're going to talk about treatment planning today. Imagine you are a client who's seeking counseling. Every time you come to the session, you vent and you tell your stories. And your counselor is very empathetic, they are very understanding, they're warm, they're an active listener, but they never talk about goals to work on. So like every time you just go there, you have a good time and you leave. How would you feel? So why do we do treatment planning? First, it holds us ethically accountable. Clients come to us every week. They don't just want to have a good time, right? They come to us, they're investing their money and their time because they want to achieve a better mental health. If we don't even have a set of treatment goals, or if we don't have a treatment plan, it's kind of hard for us to gauge clients' progress. And if they're not making progress, it's kind of unethical for us to keep seeing them. They can probably get a better service from a different provider. Second reason is that treatment plan is just needed for insurance companies in order for us to get reimbursed. And in mental health agencies and places like schools, they usually have funded programs. So for those like intervention programs or education program, it's important to have treatment plan as part of the necessary paperwork. Treatment plan helps to justify and describe the need for counseling service. Treatment planning also provides a good structures for both the counselor and the clients and help both parties see the direction of the treatment. The ACA Code of Ethics require that counselors and their clients work jointly in devising integrated counseling plans that offer reasonable promise of success and are consistent with abilities and circumstances of clients. So that is the ethical rationale for treatment planning in counseling. There are various models for treatment planning. In our textbook, Kress and Pale has provided this model, which include several components: individual counselor, contextual assessment, assessment and diagnosis, necessary level of care, personal strengths, treatment approach according to your guided theory, the aims and objectives of the treatment, research-based interventions like evidence-based counseling practice, as well as therapeutic support services. In this class, we're using an individual service plan model. As you can see, there are 7 components in this model. First, you have prioritized concern list, and then the assessments that can be used to evaluate those concerns. You also need to provide the adjunct services or referrals recommended other than counseling. Then you need to write about the objectives, which are goals that are measurable with indicators and criterion. Then you have interventions, including the level of care, the modality that you'll be using, the number of sessions, and how often do you want the client to be seen. And then you need to provide the theory behind the interventions and what's the emphasis of the theory, the actual intervention, and some treatment strategies. At last, you will have a place to provide the justifications for your interventions, theories, and treatment strategies. You will need to provide some literature support in this justification box. Let's start with the prioritized concern. This is a place where you make a list of presenting issues using very short, very brief, and concise language. Prioritized concerns should be written in kind language, in the sense that you want these to sound professional and appropriate. You want it sound like neutral, without any judgmental tone, because you don't want these issues to be tied with certain stigmas, right? And you also want these concerns to match the client's needs rather than your needs, because sometimes we as therapists, we see that the clients are struggling with something, but they probably don't think in that way. They probably think, yeah, well, even if I agree with the therapist, I still want to work on these things because these are more important to me. And you should also number the concerns according to how important they are to your client. Let's look at some examples. So in this first example, there are two prioritized concerns. The client wants to regulate panic attacks and anxiety, and also work on relationship separation. Let's look at another example. This individual needs to increase self-care and wellness, as well as increasing participation in social relationships. Another example, there are three prioritized concern lists. The client's main major concerns are: number one, abstain from alcohol; number two, increase self-care; number three, create new social relationships. Next, you want to make a list of all the assessments to be used with the client. In this class, you should always include the following three assessments: biopsychosocial history, mental status exam, and WHODAS 2.0, because they are required in this class to be conducted during an intake session. And remember, an intake interview is also a type of assessment. Let's look at some examples. In the first example, in addition to those three assessments, there are two more assessments that has been used. They are alcohol use inventory and addiction severity index. Based on these assessments, we can assume that this person may struggle with alcohol use or potential addiction issues. In the second example, we see that the two additional assessments are WISC, which is an intelligence scale for children, and children behavioral checklist, which is usually called CBCL. So we can tell from these assessments that the client is probably a minor. Then the last example, this counselor has used adults manifest anxiety scale to evaluate anxiety symptoms. In the next part on this ISP, you want to make a list of adjunct services or any referrals you would like to make for your clients. Because a lot of times, clients can benefit from other services in addition to counseling. Example services include AA, family counseling, couples counseling, if they have like relational distress, right? Marital distress. If they have addictions problem, they can benefit from inpatient detox. If they are struggling with eating disorders, or maybe they're just working on their overall physical health, they can be referred to see a registered dietitian. And maybe if they prefer group counseling, they can also, get some group counseling services, or sometimes not even group counseling. A support group can be helpful as well. Like what I have done in the past is I had clients who benefit a lot from new mom support group with her postpartum depression. When constructing ISP, making sure that the items in this category, these adjunct services and referrals, usually stand alone from the next section, which is objectives. So like if you refer someone to to conduct family counseling, you can only list this as an adjunct service. You do not list this again in the objective section. Let's also look at some examples here. So this first example include 3 adjunct services, including primary care, physician, and registered dietitian. In the second example, this client has been referred to psychiatrist, family counseling, primary care doctor, and physician. In this last example, this client has been referred out for AA meetings and couples counseling. Finally, we get to write about the objectives, aka the treatment goals. We will use the following template for each objective. Client will blank by blank as evidenced by blank. In the first blank, you want to insert an information to indicate the purpose of the objective. This purpose doesn't have to be identical to the prioritized concern, but is usually highly related to one of those prioritized concerns. In the second blank, you want to insert some sort of activity that the client will perform in order to meet this objective. And then at last, you want to provide some evidence. In the third blank, they are the indicators that the objective is being met. So you want to make sure that the objectives are measurable. That's why we are inserting some kind of activity in there. And we also put a number after that activity. Let's say if someone wants to improve their physical health, they want to do physical exercise. And you want to put a number, like how often do they want to do physical exercise? Do they do once a day, once a week, or multiple times a week? The indicator is the evidence to show that the objective is finished, the objective is achieved, right? So basically, how will the client and how will you know that something is changed? And you can do as evidenced by, or you can simply put AEB as an acronym. But one thing that I really want you to pay attention is that the evidence is not for the completion of the activity. Like in the same example, client will improve their physical health by running once a week, as evidenced by. Here, instead of putting client's journal or client's report in the session of how often they run, you want to insert some kind of assessment here. Maybe there's an assessment about this person's physical health, right? So the evidence is related to the purpose of the objective rather than the activity. And then last but not least, making sure that you use concise language because there's not much space. And usually, in order for you to sound professional, it's better to sound concise. I know this may be a little bit abstract for you at this point. I'm hoping these following examples will help you figure things out. So this person is the presenting issues are panic attacks and anxiety. And let's look at their objectives. So the first one, client will increase understanding of her triggers of panic attacks, right? So that's related to panic attacks by, and then this is activity, exploring her anxious reactions in journal. And then frequency is once a day, as evidenced by completion of feared situation hierarchy once a month. That's an assessment. The second objective, client will increase prevention control of anxiety by practicing breathing techniques 2 times a day, as evidenced by client's weekly self-reporting session of the anxiety level and week 5 scores on the adult manifest anxiety scale. The last one, client will increase healthy social skills and relationship skills by actively participating in a social activity such as singles Bible study group 1 time a week, as evidenced by ratings on clients' self-developed positive interaction skill and discussion in session. Let's look at another example of someone who struggles with personality disorder. This client will increase self-esteem by listing her interests and achievements and writing down one thing she felt went well once a day, as evidenced by client's weekly self-reporting session and increased scores on Rosenberg self-esteem scale at week 8. The second one, client will increase assertiveness by self-advocating, such as saying no, making their own decisions at least once a day, as evidenced by ratings on client's self-developed assertiveness scale each week and score on the Spencer A. Rathas 30-item schedule for assessing assertive behavior at week 12. Right? Noticing the evidence here is not like a log, keep track of how many times they said no or they made their own decisions. Rather, the evidence is to show that there's an actual increase of the assertiveness level. The next example is someone who struggles with depression. There are 2 objectives. Number 1, client will increase control of feelings of sadness by recognizing situations or times of increased sadness and changing an element of the situation at least once a day, as evidenced by BDI scores, Beck Depression Inventory scores, at week 10. Number 2, client will increase motivation by volunteering once a week at a meaningful service location, as evidenced by client's weekly self-reporting session and rating on self-developed motivation scale. So yeah, sometimes you can't find a standardized skill that can be, just very, very appropriate for the presenting issues. You can just develop one, right? You can develop one together with your client, and you can just simply say that skill is self-developed. In this intervention box, you want to include the following 5 elements. Right, the first one is the level of care. Does this person need outpatient or inpatient? Usually, if this person only needs counseling service, we just put this as outpatient, right? And the second one, you want to write about the modality, the treatment modality. This comes from your guiding theory, and you also need to specify if it's individual or if it's a group counseling. Number 3 is to write about the duration of session. Usually, if you're doing individual sessions, you can just do 50 minutes. That's pretty standardized. If it's a group session, sometimes it can be 90 minutes if there are too many people. The next element is the frequency of the treatment. Usually, for counseling, we recommend to most people to be seen weekly. Sometimes if this person has some like severe issues, maybe like severe depression or PTSD or acute stress disorder, that person can be seen twice a week or even 3 times a week. And if this person needs inpatient treatment, the counseling sessions can be daily counseling sessions, right? And the last one is to include the number of sessions. You want to identify how many weeks you want this person to be seen. Basically, what is your estimation of the prognosis of this client's issues, right? So at this point, maybe you don't know much about the duration of the counseling a person needs. This really depends on your theoretical orientation. So you want to look up online to see what your theory, what is the standardized number of weeks that are needed for your theory. Let's look at some intervention examples. So for the one who struggle with panic attacks and anxiety, this person, the counselor's intervention is outpatient, cognitive behavioral therapy, individual session, 15-minute sessions weekly for 16 to 18 weeks. And this is an intervention for group counseling. Outpatient, cognitive behavioral therapy, group session, 90-minute sessions weekly for 10 weeks. And then the last is an example for inpatient treatment. Inpatient, hospitalization, individual and group sessions, 24-hour supervision for 5 days. Or inpatient detox, individual and group sessions, 24-hour supervision for 28 days. In the box entitled Details, you want to put in a description of what you will be doing as a counselor. You will use this following template to complete this section. You want to insert your guiding theory, the emphasis from your guiding theory related to the objective. Basically, what are you focusing on as the counselor? And then the counselor will utilize blank. In this blank, you put in therapeutic technique. After that, you also write a separate sentence to describe what instrument or what kind of assessment you're going to use to measure progress. And this assessment is identical to the one that you have put in the objective box, if you still remember, because in there you're using some sort of assessment to evaluating whether or not the objective has been met, right? So then you're going to just put the same assessment here as a way to keep track of client progress. Again, let's look at some examples. From the same example, panic attacks and anxiety, the first intervention is CBT, right? That was the guiding theory, emphasize conceptualization of the panic attacks. And counselor will utilize stress inoculation training. This is an intervention. Monthly charting of FSH to track progress and indicate client outcomes. That is the assessment. Number 2, or 1B, is CBT emphasize skills acquisition to reduce anxiety related to panic attacks. Counselor will utilize breathing retraining technique. BAI score at pretest and week 4 to track progress and indicate client outcomes. And the last the last intervention, CBT again emphasize social and relational skills. Counselor will utilize social skills training. Counselor will process client-developed social interaction skill to track progress and indicate outcomes. Noticing that this person has been using CBT throughout this ISP. And that's also something you should be doing as well. Not only for this class, but in the future, I don't recommend you to try more than one theory on one client. Some of you may notice that the first two objectives are numbered 1A and 1B. Do you want to guess why it's numbered in that way? Yes, it is because that this person had two prioritized concerns. 1A and 1B are both for the first prioritized concern, and 2 is for the second concern. We want you, when you are writing the ISP, we want you to align everything up, like the prioritized concern, objectives, interventions, and details, they should all align. Let's look at another example that's using a different theory. Person-centered theory emphasizes counselor congruence. Counselor will utilize congruence to express genuine experiences of the therapeutic relationship within session. To promote social awareness, counselor will track progress by noting client-identified triggers within the session. Sometimes you come across with a technique from other theory that you think can be very helpful in your client situation. So how do you use it? You just borrow the techniques from other theories, even though you're still using your theory. This is how you're gonna write about this. Person-centered theory emphasize self-actualization of understanding relationships. And then adding this sentence, borrowing from Adlerian, counselor will utilize social interest technique, which promotes participation and belonging in the community. Now, this person can borrow this technique from Adlerian because it seems that this intervention aligns well with the self-actualization component of the person-centered theory. You don't want to borrow something that is totally unrelated to your guiding theory emphasis, or sometimes even on the contrary of your guiding theory. So be mindful about that. And then going back to this example, the last sentence, counselor will explore client self-developed positive interactions rating scale to indicate progress and client outcomes. So that's how you are documenting the measures that you'll be using to keep track of the client progress. One more example. Adlerian theory emphasizes self-acceptance and self-esteem. Counselor will support client in increasing feelings of acceptance and self-esteem by establishing an empathetic and encouraging therapeutic relationship during the engagement stage of therapy. Progress will be assessed through self-report in session and SES. The last one, CBT emphasizes enhancing self-esteem. Counselor will utilize self-acceptance techniques. Rosenberg's self-esteem scale will be used to track progress and indicate client outcomes. In this last box entitled Justification, you're going to write about the rationale for the things that you put in the previous sections, especially the objective and intervention choices. This is a place you also put some literature to support yourself. When you're doing that, remember to use APA 7th edition in-text citations. But you're not going to need to include a reference page here. And here is an example from the same panic attacks and anxiety treatment plan. In your justification, you should also keep the number consistent with the previous sections. So here you can see 1A. This objective assists the client with conceptualizing his panic attacks. The client needs to first understand and becomes aware of triggers before changing behaviors and emotional patterns. If you remember, in the objective section, this recognizing the triggers has been written as one of the activities, right? And continue, Seligman and Reichenberg 2012 recommend stress inoculation training for treatment of panic attacks. And this is also something that has been written in the both intervention as well as the objective section that we have reviewed earlier. SIT includes conceptualization of the problem, self-monitoring with relationship methods, skill acquisition with rehearsal, and real-life application of the skills obtained. Feared situations hierarchy, FSH, will allow the client to visually or concretely track his triggers and adapt accordingly. In other words, this seems to be a really good way to keep track of client's progress. That's why the counselor used FSH as a treatment progress tracking tool. I also included some more examples of the justification. I'm not going to read through, but I will leave it here as an example for you. And this is another continuation of the justification slide. So let's sum this up. You're going to do the treatment plan using the individual service plan template. There are 7 boxes for you to complete here. Actually 7 elements for you to complete here. There are more boxes than that. You start with the prioritized concern list, making a list of presenting issues using concise language. Make a list of assessments that you will be using to evaluate clients' baseline and keep track of the progress. In this class, you are always going to put biopsychosocial history, mental status exam, as well as WHODAS 2.0. And you should also include other additional assessments related to each prioritized concern. And then you write about any possible adjunct services or any referrals that you will make for your clients so that they can benefit not only counseling but other services as well. And then finally, you get to start right about the actual treatment goals. Here we call it objectives, making sure your objectives are measurable with the indicator or the criterion or the evidence to show that the objective will be achieved using the template we have reviewed earlier. After that, you will simply write down the intervention. You will include the level of care, outpatient or inpatient, the modality based on your guiding theory, number of sessions needed for this client, as well as the recommended frequency. After that, you write about details, including your guiding theory, the emphasis of your guiding theory related to the objective, the intervention you're about to use, as well as any strategies to keep track with treatment progress. And these things need to be grounded in the lecture. So in the justification part, you will be including rationale and literature support for everything you just wrote about in objectives and details section. You will need to provide APA formatted citations without a reference page. In the process of treatment planning, there are several things needs to be considered. First, you want to ask yourself, what is realistic of your client when creating an objective? This has a lot to do with their stage of change, like where are they in the stage of change? If this person is ready to move, is ready to make changes, there's not big deal. But what if this client is mandated? What if this client is still kind of suspicious about counseling? right? You need to take these into consideration when you're drafting your objectives. Is it manageable for your client? How many objectives are manageable for this client? Of course, it depends on different people, right? But usually, 3 to 5 objectives are usually a good number. Next, you want to ask yourself if you are comfortable to share the treatment plan with your client. Even though we don't necessarily let the client read the treatment plan, I mean, technically we do let them read it, but sometimes they would prefer us to review it with them together, right? You want to ask yourself if you would feel embarrassed once they see the treatment plan. If so, then you're going to need to change your language to person-centered, kind, and professional sounding language. The next question is, was the process collaborative? Did you come up with all of the objectives by yourself? Or is there a place where you and your client can discuss these things? If there has been a brainstorm process where the client can also contribute to the objectives. Of course, we would prefer the latter, right? For several reasons. First of all, you're not the client. Even though you are professional, sometimes you don't know your client better. Well, especially in the earlier stage, right? You really don't know much about your client. So trust them, give them the voice, let them contribute to the objective building as well. And secondly, that's how we can create meaning for the clients, right? We don't want to give them something that they don't want. We want them to come up with something on their own. And that is the nature of counseling, is that we don't give people suggestions. We don't tell people what to do. Instead, we help them, we empower them so that they have a better understanding of what they should be doing. And we're just there to help them kind of reframe the language, reconstruct the things, the objectives that they want to, the goals that they want to achieve. In this class, this collaboration process may not be possible, right? Because we will going to be doing case studies where the client is missing. But it's still important to know how collaborative should be the nature of treatment planning. Once again, you have reached the end of this lecture. I hope you enjoyed this video. Remember to email me if you have any questions, and I'm always open to have a fun discussion on the things that to be discussed in this course. Thank you.